Welcome to our introduction in handling of the ultrasound machine and also introduction in the examination of the abdomen. And we like to start with the knobology. That means we have to explain some of the switches and bottoms, and we start to choose the right probe. We have in this machine, on the left side you can see the keyboard of the machine and the screen where you can choose the preset of what you want to use and some of the switches. And we have two probes. This is the convex probe. You can see it. That is a curved array. You use that for the abdominal examination. And the other one, that is a linear probe that has a higher frequency, 5 to 10 megahertz, and you use it for the examination of the thyroid, of lymph nodes, and also for the vessels. The convex probe, we start with that probe and we use for the abdominal examination.
Good morning, teacher and dear friend. It's my honor to join you for the workshop. My topic this morning is about artifact of ultrasonography. As you can see here in the picture, there should be some artifact. For example, here an image on the surface of the lake is not real, so it should be artifact. But the others here are real structures, or for example, the swan. I'm Yi-Hong Chow from Taiwan, and now serving as chair professor at UMB University, Taiwan. Why there are artifacts during sonographic study? Some could be resulting from improper equipment operation, improper equipment setting, improper scanning technique, and some are related to ultrasonic factors. I would like to emphasize the ultrasonic factor because it is related to interaction of sound wave with transducer or tissue in human body, and sometimes cannot avoid. Almost all ultrasound equipment have a certain handling assumptions. For example, all tissue has the same acoustic velocity. Ultrasound energy travels in straight line in tissue. Distance proportional to round-trip travel time. Echoes originate from points along the main beam axis. Echo's intensity is related directly to the reflection or scattering properties of object, and all detected targets are on the central ray of the transducer beam pattern. So if there is any assumption of violated, an artifact occurs. Starting from the multipath artifact, so-called multipath is a kind of multiple reflections. For example, reverberation artifact, Comet Tail, rain down, mirror image, and mirage artifacts are related to multipath. A typical example is just like this. When you scan the lung, you can see a lot of reverberation artifact. This kind of artifact is a kind of reflections one by one, and the subsequent refractors is weaker than the prior ones. It's because the reflection between the transducer and the strong refractors here, for example, this lung, air. So air is a real one, and the others are reverberation artifact. Why the air is so strong in reflection? Here you can see the impedance of air is about 0.0004. That means air is very soft, very compressible, but bone is very hard, and soft tissue in between. And talking about the refraction coefficient is related to the difference between two refractors. For example, the muscle 1.6 and the air 0.0004, so the difference is huge. Therefore, the ZO2 minus ZO1 divided by ZO2 plus ZO1 in this example will be about 100%, almost 1, so 100% refracted. That's why air, whenever you encounter air, almost all are refracted, all the energies. So here is a typical example by schematic representation. That's a real lung because it's reflected back to the transducer, but the transducer is also a strong refractor, so bound back again and again, so the second, the third, the fourth, and each subsequent refractions is weaker than the prior one. So here you can see reverberation, and here a relatively complicated reverberation is so-called dirty shadows, because it makes a lot of different refractors here. There's a corresponding CT pattern. I magnify this for you to see the wall of the stomach and the air and the reverberation. Reverberation is not only noted at lung sonography or small bowel study, and here is an example of Stockholm renal stone, also causes this kind of reverberation. Not commonly seen, but occasionally. And reverberation here is not a reverberation, it's a kind of mirror image. Here you can see the viscera lung, viscera pleura or lung, and here is the muscle, that's a diaphragmatic muscular bundles, and here you can see in between liver and the diaphragm there's a liver capsule plus parietal peritoneum, so the muscle diaphragm here reflected to here, so this is a mirror image, and for this there's a real, and this is mirror image of the interface between muscle and the liver. So this diaphragmatic presentation, and here scanning the liver right lobe, you can see a hyperechoic structure. It should be most likely hemangioma, but here you can see another one. Actually, this is not a real one. There's a reflection from this real structure, so there's a pseudo hemangioma above the hyperrefractor here. That's the viscera pleura or lung. Just like this, A is a real one, A prime here, a pseudo hemangioma. and sometimes sissy structure can also reflect it above the diaphragm. Here I can see something above the liver and above the diaphragm, just like a cystic structure. Should be real. I do it again, I can see this. But sometimes I cannot see. So here you can see the real structure in the inside the liver. That's inferior vena cava and prominent hepatic vein. Is that artifact? Now I can see both sides. One below diaphragm, one above diaphragm. This is real hepatic vein and IVC. This is refracted structures from below the diaphragm. So this is a mirage artifact, real image. This is a mirror image. True, false, false, true. Sometimes can be so real, the artifact. Here you can see completely reflected above the diaphragm. So false and real. Mirror image artifact. Now about ring down. A very important study by Cooperberg group in 1985 to demonstrate the gas bubbles inside a water bag can cause this kind of air bubble artifact or ring down artifact. The schematic representation here to show you the air bubble and in between the fluid trapped inside. So when the sunbeam, the main ultrasound beam, transmitted to the fluid and reflected in between the gas bubble, then a continuous source of sound energy go back to the transducer. So you can see this kind of parallel refractions. Again, there's a mid-abdomen and lower abdomen by doing a transvaginal ultrasound because of a small bowel gas. And in the upper abdomen, quite often you can see this kind of a reverberation artifact, a specific reverberation artifact, ring down artifact, arising from the gas bubbles in the stomach. How about this? It's just like Comet Tail, right? So this is a kind of a Comet Tail artifact caused by tiny stones or crystals in the hydronephrotic kidney. And here an IUD inside the uterine cavity. There's a Comet Tail artifact arising from the metallic object. And not uncommonly, you can see the artifact from the crystal crystals, tiny calcifications or small stones. Refraction artifact. Just like light, sound can also have this kind of artifact. It is it should follow the Snell's law related to velocity, not acoustic impedance. So here you can see two different medium. The first medium got velocity v1 and the second medium got velocity v2. If v2 is greater than v1, then the sunbeam hit the surface of second medium, the sunbeam will be deviated and then deviated again because hit the v1 through v2 hit v1. So you can see the sound go like this, but because the machine just think the refractor should be a straight line, a sunbeam should penetrating through this structure by a straight line, so this structure will be placed in this area. So B is a force displaced. Okay, now about reflection and reflection combined together to cause a critical angle artifact. Here reflection, here refraction, and then you can see two critical angle artifact or lateral shades on the margin of the CC structure. In this example, that's gallbladder. Okay, and not always on the margin of the cystic structures, but sometimes from the curved or oblique reflectors. Here is an example from the Farsovan ligament or round ligament. Also a kind of a reflection artifact. Reflection artifact from a hepatic cyst, but here is that a kind of a critical angle artifact, but here you can see a little bit dirty, so not quite typical. Actually, this is caused by air bubbles on the gallbladder wall. So this is so-called emphysematic cholecystitis, air bubble trapping on the gallbladder wall. And here there's a spleen, that's the left kidney, but why the left kidney is crooked like this? Because of refraction from the different velocity. There's a spleen faster, fat slower, so the lower part of the kidney is depressed distally. So it's a kind of refraction artifact plus spit error displacement. And here, two Foley catheter bubble, four catheter balloon, just because of the rectus muscle here serving as lens, and therefore refraction occur, and one balloon look like two balloons. And in this situation, you can move the transducer lateral to the midline, then you can see only one single balloon. Side lobe artifact is because of the energy from side lobe. The main lobe is sunbeam we used for sonography study, but the side lobe signals can be also detected. So that's a main lobe detected is a hyperrefractive structure, but side lobe also sees this and register the signals on the side of the hyperrefractive structures. So side lobe here. Now another commonly seen side lobe is on the braided base. Here you can see two side lobes along the hyperrefractor. And now slice thickening artifact. It's just similar to partial volume artifact on CT because the sunbeam got three dimensions. One for axial resolution, one for lateral resolution, and here is the slice thickness. So it's so-called elevation resolution because the elevation or slice thickness is too thick, then it will detect some signals on the peripheral region, not in the main beam side. So it can display as weak internal echoes, just like here in the gallbladder. So slice thickening artifact. Everybody knows this because that's caused typical acute shadows from gallstone. But how about this? There's a larger hyperechoic with acute shadows. Could be intrahepatic stone, but actually not. It's fat. So lipoma can cause this kind of acute shadows because of the strong attenuator. Or here another strong attenuator. That's fatty tumor, actually liposarcoma, retroperitoneum. So acute shadows or strong attenuation. And attenuation can be also encountered during sonography study for fatty liver, particularly if you are using high frequency transducer. The distal portion is strongly attenuated. So acute shadows can be clean like goldstone, can be dirty like air. There's a kind of complicated reverberation artifact, and also from the critical angle artifact or refraction artifact. And if the structure here between the inside the liver parenchyma is a weak attenuator, then there should be distal enhancement or increased through transmission here. Again, enhancement, critical angle artifact in the typical renal hepatic cyst or gallbladder. So in conclusion, artifacts are commonplace in ultrasound. Often these errors in image display are unavoidable and occur secondary to intrinsic physical properties of the ultrasound beam and its echoes. Artifacts are important because they may be clues to tissue composition and may aid in diagnosis. There are common examples. You know the answer. There's a ring down artifact. How about this? Comet Tail, no doubt. Comet Tail. How about this? Double Foley catheter balloon. So there's a refraction artifact or lens artifact, sometimes called phantom or ghost artifact. And here you can see something wrong with the liver. It's bright here, it's dark here. Is the hyperechoic area focal pathology? No, that's because of fluid ascites enhanced the liver here. How about diaphragm here? Seems to be interrupted. Actually, that's caused by liver. Different velocity between liver and ascites. So the diaphragm seems to be interrupted. And so you know the nature is a combine of speed, error, displacement, and refraction. So thank you very much for your kind attention. Any questions?
This will be a repetition of something you have already heard, ultrasound terminology, what is echogenic, what is hyperechoic, what is echo-free or anechoic. I will give you also a few examples of artifacts and will show you examples which can be only interpreted on the basis of clinical information that repeats clinical ultrasound. And of course, this is an invitation to the next students webinar in July, because the main topic will be biliary ultrasound, and therefore I choose this topic, the many ultrasound phases of the gallbladder. you have already seen in the demonstration of Professor Nürnberg the normal phase of gallbladder. And here we can repeat that the inner of the lumen of the gallbladder is anechoic. And another term, and it is equal, is synonymous, is echo-free. The wall of the gallbladder, on the other hand, is echoic, hyperechoic, you can see also in comparison to the liver. And the liver is that organ which helps us to decide on echogeneity of the other organs, because we always need a comparison to a reference organ. And in most cases, on the right-hand side, we use the liver for comparison. For example, if we have differences between the gallbladder and the liver parenchyma. In other cases, we use renal parenchyma for comparison. If we have to decide on fatty liver, then we will have the comparison to the renal parenchyma. And this is another normal phase of the gallbladder, and that is related to clinical ultrasound. If you have not the information that this examination was done after breakfast of the patient, you will fail in your clinical diagnosis, because you have a thickened 3-layer gallbladder wall. But this is normal because this is postprandial contraction of the muscles of the gallbladder wall, and therefore this is normal finding. Otherwise, if the patient would be not after breakfast or another meal, then the clinical interpretation would be another one, another normal phase of gallbladder. Now we have the stony phase of gallbladder. This is very common, and in most cases, these findings of gallbladder stones is incidental. As in this case, this was a 75-year-old male. He came to us with diarrhea. We performed ultrasound to examine the bowel, and of course we looked to the gallbladder. The patient had normal liver enzymes, and therefore this finding is an incidental finding. It would be another situation if the patients would have come with epigastric pain, for example. And again, the lumen of the gallbladder is anechoic or echo-free, and we have a very hyperechoic stone, which causes an artifact, and this artifact is shadowing, because the sound, the ultrasound will not pass, the ultrasound waves will not pass this total reflector of the gallbladder stone. And I will show you another artifact which may be not important for gallbladder stones, but it is very easy to demonstrate here. This is another example of a simple solitary gallbladder stone within a normal appearing gallbladder. But if we, in this case, activate our color Doppler, then we will have this phenomenon. A lot of colors, different colors from red to blue, and this is called twinkling. It will not help us to identify this stone. We have seen it, it is clear, but this is a physical phenomenon which is like the reverberation artifact, which has been shown you already, and it may help you, for example, to identify very small stones in the kidney, which are not so good visible as, for example, this large gallbladder stone. Now, the next case is the hot phase of gallbladder. This was a young lady 1 week after delivery of her healthy and very lovely daughter, and she came with acute epigastric pain, vomiting, fever, and elevation of inflammation parameters. And this is the image of the gallbladder. The patient is in the left lateral position, and maybe that we now can use the chat. What you can see, what is not normal in this patient, and will help us to decide on the diagnosis of this young lady. Have you any ideas? Please write in the chat or tell it. We are only 20 people, and you can activate your microphone if you want. I repeat this, Avi. There are several pathologic findings. Here's one, and the other is here, and the third is here. No ideas? Okay. Then let me tell you that these echogenic reflexes causing small shadows are very small stones.
Excuse one comment in chat. Okay. Small polyps. Another wrote sludge. Okay. It is in between. Here we can see, let me stop at this point. Here we can see that these, back here, that these echogenic reflexes cause shadowing here, here, here. And therefore, these are not polyps. Of course, we can try to give the patient another position to see that these stones are rolling or moving, but these are really small stones, and the small stones often cause colics, as in this young lady, but she had not only pain, she had fever and elevated inflammation parameters. And what's this? I have shown you the normal phase of gallbladder. That means this thinny hyperechoic wall, and another example of a patient after breakfast with a little bit thicker wall with 3 layers, but here is a thick wall and no layer. And if we turn the transducer, we see that there is also, look in this region, that will come in the next moment. Here we have a little bit anechoic material, which is fluid. That means we have a very acute cholecystitis caused by these very small stones. Here again, the picture, and you see that wall is heterogenic, and there are anechoic parts, and there are hyperechoic parts and medium echogenicity parts, and this reflects the edema, the inflammatory edema of the gallbladder wall. And we see here vessels within the gallbladder wall, also in the liver, of course, with color-coded duplex. And this one is not a vessel. This is twinkling artifact, color-coded reverberation, caused by these very small stones. One of our participants wrote cholecystitis. I think that's a severe cholecystitis. Yeah, do you agree? It was really a severe cholecystitis. Yeah. The patient was very ill and was a bad situation because she had this small daughter of 7 days and gave her milk, but she had to be operated. But here you can see with a high frequency ultrasound transducer with a frequency, I think, of 12 megahertz, that we can have a better resolution of these pathologic changes in the wall of the gallbladder. And you see here these very small fluid-filled spaces, anechoic, and this is the edema of the cholecystitis. Here's the other view. Yeah, but there's also some free fluid outside of the gallbladder. And what is the difference to an perforation? I may show you an example of some perforation. But in some cases, it is not to be decided. But in most cases of severe cholecystitis, you have only a little amount of free fluid only around the gallbladder. Yes, this is this phase of gallbladder with holes.
in an 80-year-old male, and he also had acute onset right upper quadrant pain, but it was 5 days ago, and now the pain was better, but liver enzymes were elevated. The condition of the patient was better, and he had elevated inflammation parameters. And this is the gallbladder, and this is the liver. And I used color-coded duplex sonography. And you can't see it, but here's my transducer in this region. Sorry, here's the transducer. And sometimes I press a little bit the transducer onto the liver. Sometimes I take back the transducer, and this is the result, red and blue. You didn't hear anything on color-coded duplex sonography, but you should know that a red flow is directed onto the transducer, and the blue flow is directed away from the transducer. And now I release the transducer, now I compress the transducer. And do you have any idea why there is some flow between this pathology and the gallbladder? Do you have an idea?
Perforation.
Yes, good idea. This is a perforation, and this is no blood flow. Any type of flow of fluids can be seen with color-coded duplex sonography. It depends on the flow velocity, and this is flow of pus between this abscess in the liver and the lumen of the gallbladder. And this indicated a puncture of this abscess and a drainage of the gallbladder. I will not show you, but you can see you can use artifacts, like in this case an artifact. It is an induced flow of pus, in this case between two cavities, to help you to establish a diagnosis. Now we have the swollen phase of gallbladder, and this was a young man. He was completely painless, but had markedly elevated transaminases, and diagnosis was acute hepatitis. At the moment of examinations, we didn't know this diagnosis, but he had this very much elevated transaminases. And look at this gallbladder. Is this also an acute cholecystitis? There's again a very thick gallbladder wall with anechoic tubular structures, with this echogenic structures, and the thickness of this gallbladder may be, yes, 2 centimeters. And if we go back to this movie, we can see that there's also some free fluid, anechoic, around the gallbladder. And there's something inside the gallbladder. We can see here in this region, and here's a free fluid. Now, what do you think? Same diagnosis as in the young lady, but he is painless, and he has no elevated inflammation parameters.
Edema.
Yes, this is non-inflammatory edema, and we have that, for example, in patients with a very low protein amount in the blood, or in patients with liver cirrhosis. And in this case, it is not so often to be seen, but in very acute types of hepatitis, for example, in dengue fever or in acute hepatitis A, we see such maximum edema of the gallbladder wall. And if you decide to operate such a patient, this would be a very big mistake and can cause complications of this patient, because he has an acute hepatitis, or in other cases, another acute disease causing this edema. Therefore, our clinical evaluation will help us to avoid a wrong diagnosis. This is edema, but not related to inflammation. And I think this is the last example, the special phase of gallbladder. This was again a patient without any symptoms, but he had a screening ultrasound. I don't know if this is a good idea to have a screening ultrasound. We can discuss it. And we found this example of a very nice pathology. Would you like to comment on this? What do you see? And I would like to have not a diagnosis. I would like to have first a sonographic description using the terminology we have learned, and second, an idea of a clinical diagnosis.
In chat, polyp.
Okay, this is a clinical diagnosis, but we are in a basic course and we would like to train ultrasound terminology. Please describe this polyp. It is a polyp, of course.
Another one wrote that's hyperechogenic and no shadow.
Okay, this is a good description. I would add this is a little bit heterogeneous. It is hyperechoic. It resembles the gallbladder wall, but there are small areas which are hypoechoic. That means this is a heterogeneous echo pattern. And I would mention a stalk. In this case, we can see the connection to the gallbladder wall and a little bit irregular outline of this polyp. And I can show you that we can show very nicely with a combined technology of contrast-enhanced ultrasound and slow flow Doppler that in this stalk there's a small vessel which divides into branches, and this polyp has the same vascularity, the same contrast enhancement with ultrasound contrast agent as the liver parenchyma.
Some of our participants described some very small cyst inside, and I think that are the vessels. Do you agree?
I don't know. The patient is not operated yet. We decided to send him to surgery, but now is Corona time and he decided to wait a little bit. Maybe that some of these anechoic or hypoechoic areas are vessels, but maybe that others are cysts. And there's a lot of variety of differential diagnosis for this polyp. It may be a large cholesterol polyp. One argument is a very small stalk, but it could be also adenoma, and there are some other types of polyps which have small cystic lesions, and I wait for the pathology report after surgery and will report again if you want.
Thank you very much, Christian.
One example, if you have 1 minute.
Yeah,
do we have? Yeah, the cruel phase of the gallbladder. We have to end with the worst case. And you see, this is a gallbladder and there's a gallbladder stone. But the gallbladder stone is inside an heterogeneous hypoechoic mass lesion in the fundus of the gallbladder. This is a movie, gallbladder, and this is a tumor of the gallbladder which incorporates the gallbladder stones. They are enclosed by the tumorous tissue. Here are some smaller gallbladder stones. And this is, of course, an already advanced stage because we see here also some liver metastasis. And this was really the last example. Thank you for listening and thank you for looking at these videos and images.